Hi everyone, welcome to another Monty Hart lecture. Today we have the great honor of having Dr. Renu Virmani, who will be speaking about what I have learned from examination of cases of sudden cardiac death. Uh, Everyone here probably knows Dr. Virmani already, but maybe for some of the fellows that may not know her, Dr. Virmani is an internationally renowned cardiovascular pathologist, recognized as the leading researcher in the field of cardiovascular disease treatments, and presently serves as the President Emeritus of CVPath Institute, which she founded in 2005. Dr. Virmani received her MD from Lady Hardinge Medical College in Delhi University, New Delhi in India. She has lectured at scientific meetings all over the world. She has actually delivered more than 600 presentations already and has authored or co-authored over 1,200 publications in peer-reviewed journals covering atherosclerosis, vulnerable plaque, stents, and other cardiovascular diseases. She has edited 7 books, written more than 500 book chapters, and is also a manuscript reviewer for many top scientific journals and has helped us with progress in cardiovascular diseases as well. Among numerous outstanding honors and awards, Dr. Virmani has delivered the Laennec Clinician Educator Lecture Award for the American Heart Association in 2010. She has received the TCT Career Achievement Award from the Cardiovascular Research Foundation in 2012, the ICI Innovations in Cardiovascular Interventions Award in 2013, Female Luminary Award from the Society of Cardiovascular Angiography and Interventions Foundation in 2016, and also has received an honorary degree from the University of Antwerp, Belgium, as well as many other awards, including the European Society of Cardiology, EuroPCR, TCTAP 11th Master of Masters 2021 Award, and the SCCT 2024 Agathon Award. Dr. Virmani was a clinical professor in the Department of Pathology at Georgetown University, University of Maryland in Baltimore, George Washington University, and the Vanderbilt University. From 1984 until 2004, she was a chairperson of the Department of Cardiovascular Pathology of the Armed Forces Institute of Pathology for 20 years. She's a member currently of the American Heart Association, the US Canadian Academy of Pathology, and is a fellow of the American College of Cardiology. So really congratulations on all the amazing things you've done, for this field that we're very passionate about, and we're looking forward to your lecture.
Thank you so much for this long, although not deserved, really speaking. I'm an ordinary human being. I've done basic work trying to understand coronary artery disease. That has been my passion. So you'll hear more about coronary artery disease today and not just everything about sudden cardiac death necessarily. So I start with coronary artery disease and death attributed to cardiovascular disease. If you look at as age advances, especially in the hypertensive patients, the mortality rate is fairly high. And that, as you can see from the 1990s onwards to 1980, when it almost peaked, the incident that's attributed to cardiovascular disease. And then since 2000, it has declined, as you can see, up to 2000, 2005. But since then, there's a small blip upwards. You can see this in males as well as females. Perhaps this has something to do with prevention or not. I think my feeling is we don't do enough prevention in this country. So going forward, I want to talk about sudden coronary death. The definition of sudden coronary death that we have used and currently is in use, that death occurs within 1 or 6 hours after the onset of symptoms. It is witnessed cardiac arrest or within 24 hours of the time that the victim was last seen alive in normal state of health. As you can see, it varies from those less than 35 years versus greater than 35 years. Coronary artery disease dominantly occurs as a cause of death in people dying suddenly beyond 35 years of age. Whereas if you look at the younger age group, hypertrophic cardiomyopathy is one of the larger causes of death, and along with it, many others. So what we did here at the CV Path Institute, we started collecting, making a database, which started as a grant from the NIH, that we, in 1994 to, this is up to 2019, but looking at, as you can see in the 1990s, we had 575 cases in 2000, 1,642, and now 1,352. So if you look at the division, cardiac death from coronary causes, this is cardiac death from non-coronary artery disease, and then stents and CABGs. You can see that we started with a larger number in the 1990s with sudden coronary death. This number has slightly decreased and even much less now, since we can't collect as much as we used to. So if you look at I'm going to talk about atherosclerosis first. And if you look at the American Heart Association, which was published in 1995 or so, they divided into 6 types. The nomenclature was type 1 to type 6. They had intimal thickening, fatty streak, intermediate lesion, atheroma, fibroatheroma, and complicated lesions. And the growth from lipid accumulation, this was accelerated by smooth muscle cell and collagen, and then thrombosis and hematoma. But one thing to remember, they thought of thrombosis occurring only from one cause, and that was plaque rupture and thrombus formation. So majority of the time, the early lesions are silent, and silent or overt can occur beyond that. So we in 2000 published our classification into progressive and non-progressive coronary plaques. Non-progressive is adaptive intimal thickening, which almost always is seen whichever artery has blood flow in it. And so it is seen as soon as after birth, even in about 30% of patients near bifurcation lesions. Intimal xanthoma was what was originally called fatty streak, is the accumulation of foamy macrophages in the intima. Then what I call progressive lesions, the lesions that progress into necrotic core are pathologic intimal thickening, lipid pool, and I'll come back to that. Then there's fibroatheroma formation with a necrotic core and a fibrous cap. Then comes the thin cap fibroatheroma, which didn't exist in the American Heart Association classification. Then we showed that the cause of coronary thrombosis occur from 3 different causes. One was plaque rupture, which occurred in 60 to 65% of sudden coronary deaths, are those with thrombi. If you look at erosion in 30 to 35, there could be pathologic intimal thickening or fibroatheromas, but the fibrous cap was thin. There was no rupture, as shown here. You can see the rupture. Whereas in calcified nodule, it was 2 to 7%. That is, the calcium protrudes into the lumen and overlies the thrombus forms over it. And of course, there's disruption of the fibrous cap. Now, if you look at progression of coronary atherosclerosis, it can occur from intraplaque hemorrhage. Thin cap fibroatheroma can rupture silently and give rise to a thrombus, which can heal. Could be fibrocalcific plaque. This is showing you the heel plaque erosion. This is showing you heel plaque ruptures can occur silently or overtly. And then chronic total occlusions. This is what we classified at that time, showing different areas of plaque type that are seen in those dying in sudden coronary death. So if you look at what we did over the decades in 1990s, we found that plaque rupture was fairly common, erosion was not as common, and calcified nodule and a stable plaque was far more common or equivalent to what was plaque rupture. Then if you look at this is in males, and then you look at 2000, in the 2,604 cases, the incidence was not that significantly different, but slightly less. And 11% of cases had plaque erosion, and calcified nodule was rare. 53% had stable plaque. Overall, as we've moved on to the 21st century, we find stable plaques being far more common. And that may have to do with the statins and the ability to treat hypercholesterolemia. We also looked at females, and if you look at females in the 1990s, the most common cause was plaque erosion, not plaque rupture. If you look at the 20s, similarly, plaque erosion is much more common in women than in men. And same way in the 2010s, again, plaque erosion is common, but it varies depending on how cases are collected over time. So when we published our classification, Dr. Starry from the American Heart Association at that time wrote an editorial. And in that, he divided these plaques, modified classification. He did it in the ATVB journal in 2000 when we published. He wrote the editorial. He divided into isolate macrophage foam cell, that is fatty streak, multiple foam cell layers, isolated extracellular lipid pool, which we called as pathologic intimal thickening. Then there's confluent extracellular lipid core form, that is the fibroatheromas, fibromuscular tissue, then called it surface defects. This is the rupture site. Then calcification predominates and fibrous tissue predominates. So it's not as clear as what we still have shown, that there are three main causes of thrombosis, and therefore the plaque types vary from the underlying cause of thrombosis. So here in 2016, we further classified it. Non-atherosclerotic intimal lesions remain the same, but progressive lesions, we divided pathological intimal thickening without macrophages, and the next phase come macrophage infiltration. Then we showed that in fibroatheromas that form, there are early where you see macrophage infiltration within that lipid pool area and converting it into necrotic core. And then here we show late fibroatheroma with a nice necrotic core. And then, of course, the thin cap fibroatheroma, as we'd done before. So lesions of acute thrombosis are plaque rupture with a thin fibrous cap, which ruptures, and the necrotic core comes in contact with the flowing blood and causes a thrombosis in the lumen. Plaque erosion, you can see, occurs in about 32%, underlying pathologic intimal thickening in 16, and 84% show us fibroatheromas. But mind you, the fibrous cap is thick. This is really loss of endothelium, and I'll come back when I talk about it. Calcified nodule, on the other hand, is the nodule of calcium which protrudes into the lumen, and there's an overlying thrombus. We didn't address plaque fissure, and recently we've addressed this. The Davies many years ago showed that fissures occur in lesions that could have plaque rupture or not. We were more interested in finding out, is fissure occurring as a separate mechanism of intraplaque hemorrhage? There's communication of the lumen with the necrotic core, and this fibrous cap need not be thin. This could be a thick fibrous cap, and you can see that there's, but usually there is absence of luminal thrombus in these cases, and there are about 11% of cases, besides the thrombi, there are 11% cases of plaque fissure. Then, of course, the other lesions, intraplaque hemorrhage, heel plaque rupture. You can have a single layer. You can have multiple layers of repeated plaque ruptures occurring, and I'll show that later. You can see there could be silent thrombosis and luminal occlusion, which may heal over time and seen as chronic total occlusion in patients. Good 30% of sudden coronary deaths have chronic total occlusion at the time of when they're dying suddenly. So they must have had an episode which may have been silent or could have been, but they never complained of any or never saw a physician at that time. Fibrocalcific plaque, of course, when plaques over time heal, they then undergo calcification, and I'll address the calcification area as well. Then there is nodular calcification. It can have a fibrous cap, the nodular calcification, which could heal and then lead to nodular calcification. And then fibrous plaque, which is really when the thrombus propagates, it can heal and eventually form just fibrous plaque itself. So let's talk about early lesions. How do they progress? So I said that if you look at pathologic intimal thickening without macrophages, you find these areas of lipid pool. These are proteoglycan-rich areas. They will have no macrophages, may have a few T cells, and the vasovasorum, depending on the thickness of the plaque, you may see vasovasorum. Then you see PIT with macrophages. You can see in the luminal side, there are a large number of macrophages, and they, with time, infiltrate into that lipid pool area, as shown here. There are T cells, there are vasovasorum, same way. If you look at early fibroatheroma, this is a lipid pool area, which is infiltrated by macrophages, as shown here, and that those macrophages release MMPs, and they then digest the matrix so that there is no matrix. Eventually, in late fibroatheromas, you can see this. If we stain with collagen, this will not stain. As you can see, we are not seeing any staining in this area because this is a necrotic pasty material instead, or gruel, which is also known as gruel. And then you can see T cells increasing, and you can see far more vasovasorum. Now, when we also looked at macrophages, we were interested in trying to understand what happens to macrophages, what is known as efferocytosis. If you look at early pathologic intimal thickening with macrophages, what we find is we find the macrophages showing apoptosis, and that apoptotic bodies are taken up by other macrophages. However, these macrophages become so engulfed with lipid that they no longer can take up apoptotic bodies, and that is known as efferocytosis, and that they are unable to digest anything, and therefore it goes on and forms what is known as the necrotic core, which can also enlarge, and I'll come back to that in a moment. So if you look at IELs, if you look at internal elastic lamina area, plaque area, percent stenosis, necrotic core, macrophage, apoptotic bodies, and percent of engulfed apoptotic bodies. This goes down because those macrophages are no longer efficient. Efferocytosis can't occur. So if you see here, you see the IEL increasing. You can see plaque area increasing. You can see percent stenosis increasing. Necrotic core formation only occurs when there is fibroatheroma. Macrophage increase over time. Apoptotic bodies increase over time, but the engulfed apoptotic bodies decrease because these macrophages are no longer efficient and can't take up apoptotic bodies. So if you look at lipid pool areas, as shown here, this is PIT without macrophages, PIT with macrophages, fibroatheroma, late fibroatheroma. You can see that these lesions are rich in hyaluronan and versican, but not so rich in biglycan and decorin. And as time goes on into late fibroatheroma, there is almost absence of these proteoglycans. And we also did oil red ore stain to see when do we see the fatty streak lesions. You can see definitely there is lipid. Oil red ore staining red shows the globular droplets. PIT without macrophages, these are microvesicular lipid droplets. Then you see PIT with macrophages, you can see that the macrophage area is staining very highly. And then when it becomes a fibroatheroma, you can see it is going into that necrotic core and becomes much more globular. And late fibroatheroma has even more, and the fibrous cap gets less of the lipid itself. So this is by Nakagawa, who's very nice paper. He shows that diffuse intimal thickening, there's fatty infiltration, which we have not been able to see. We see it only in areas of lipid pool formation as shown here, and that's when it is proteoglycan rich, which binds to the lipid ApoB, and you can see presence of ApoB in these lipid pools. That is, with one proteoglycan present, 4 molecules of lipid can bind to it. So what happens in pathologic intimal thickening is an area of lipid pool that converts into a necrotic core, and that the macrophages, it could be oxidized LDL or LDL, and then there are different types of macrophages, and I'll address that at the end, saying that we ought to study what are the different types of macrophages. So let's go to a little backwards now, talking about positive remodeling. This was work from Glagoff, who very nicely showed the Glagoff phenomenon, that the lumen remains the same until there is 40% area stenosis. Means if you take the IEL and from which you take the lumen measure, you will, as a percent, you'll see 40% narrowing. But the lumen is no different from the original lumen to as much as 40% narrowing can occur. The vessel enlarges instead. So when you see here, beyond that, how does narrowing occur? As shown here, beyond that, narrowing occurs. I believe majority of it occurs from silent plaque ruptures or from intraplaque hemorrhage, and that these silent ruptures, certainly it can enlarge the necrotic core and the lumen will narrow. And same way, if there is silent rupture, you can see that this rupture can heal and increase, and the vessel can no longer remodel anymore. And because the healing occurs fairly quickly, within 2 weeks, you can see a new intima formation. So if you look at one of the things that we also described many years ago in the New England Journal, showing that hemorrhage is an important source of free cholesterol. Red cells are the richest in free cholesterol of all cells in the body. And that if you stain for glycophorin A in areas which show you free cholesterol present, crystals present, they stain around it with glycophorin A, that is the red cell membrane, is showing you that these membranes, these cholesterol clefts have come from the red cell. And that this shows you macrophage presence. And what we did was we showed that anywhere there is hemorrhage, it doesn't have to be in the plaque, anywhere in the body, like you get hemorrhagic pericarditis, you'll see cholesterol, you'll see that free cholesterol esters, you can see crystals, and you can also see macrophage and iron deposition. The hemoglobin is converted by macrophages into hemosiderin. So in the plaque itself, you can see we looked at PIT, no core PIT, early core PIT, with fibroatheroma early core and fibroatheroma late core, and thin cap fibroatheroma. You can see glycophorin A staining increasing as plaques enlarge or become thin cap fibroatheroma. Iron deposition is also seen. Necrotic core is formed, as you can see in these areas. And if you look at macrophage infiltration, they also increase. So we think part of the free cholesterol that comes into the necrotic core comes from the red cell membrane, because if you do in culture, try and produce free cholesterol or crystals from foam cells, there are very few crystals that'll form. So the main source likely is from red cells. So we also looked at, if you look at here, 60% thrombi sudden death, this is the fibrous cap from plaque rupture. You can see this fibrous cap. You can see the underlying necrotic core as shown here. And you can see that the fibrous cap is discontinuous. There are very few smooth muscle cells. There are T cells seen. There are macrophages seen as shown here. And that there are HLA active, HLA-DR positive cells. That means they're activated. This is just to show you the propagated thrombus. The site of rupture is here where the arrow points. This is the site of rupture. This is the necrotic core. And you can see this area is rich in platelet. This is staining by platelets. But from here to here, there's a branch coming left diagonal coming off. And you can see that this is a propagated thrombus, looks very different. It is layered thrombus. There is more of fibrin and less of platelet itself. And that shows you that this is the propagated thrombus, looks very different. So in other words, what are the features of plaque rupture? You have a luminal thrombus, you have a large necrotic core, greater than 30%. We measured these and shown this. Fibrous cap that covers is thin. Thinnest is less than 65 micron. The thickest is usually less than 65 micron. Many macrophages, few smooth muscle cells. There's expansile remodeling, neovascularization, vasovasorum are seen from plaque, likely source of plaque hemorrhage, and of course, plaque fissure also. The adventitial perivascular inflammation is also seen, but they are rich in B cells, spotty calcification, and inflammation at the intimal medial border we've seen as well. So if we think these rupture sites, we believe that these rupture sites, these thin cap fibroathromas eventually go and rupture. And what are the differences in them? The difference is thin cap fibroathroma is less than 65 micron. Cap infiltration is by macrophage T cell. Cap composition is type 1 collagen. There are very few or absent smooth muscle cells and a large necrotic core, positive remodeling. And the rupture, of course, I've shown you that I haven't shown this, we measured the fibrous cap thickness at the site of rupture and showed that the cap thickness was 23 plus minus 19 micron. So if you take 95 confidence, it is less than 65 micron. Cap is infiltrated, necrotic core is large, positive remodeling, and mild to moderate calcification is seen, and I'll come back to that. So I want to talk a little bit about how plaques enlarge. As I said, you can see in this particular case, this is a silent rupture. This is dye we injected. And you can see this, the thin cap, there's a little necrotic core, which is cap has ruptured here, and there's a thrombus. And you can understand that this can heal and then will narrow the lumen at the same time. It can also occur from intraplaque hemorrhage. As shown here, the lumen is narrowed. You can see how it's bulging into the lumen, this amount of hemorrhage. So many years ago, Davies showed that this was one way of plaques enlarging. What he showed was when he looked at plaques less than 20% narrowed, 21 to 50% narrowed, you could show that there were very few heel plaque ruptures, 16 to 18%. However, when the lumen narrowing increases to 50% and greater or 51% and greater, you can see that 73% showed us heel plaque ruptures. So that tells you how plaques enlarge. What we did was we looked at multiple sites of rupture. Here we're showing a single site. You can see this picrocerus red, which under polarized light shows you type 1 collagen. The fibrous cap is made of type 1 collagen. The heel lesion is type 3 collagen usually. As you can see here, it's green by refringence. So you can easily tell this apart. And you can see what we did was we said if there's a single rupture or there are multiple ruptures, what is the percent narrowing? When there's single rupture, the narrowing was about 55%. When you go to 2, 3, and 4, you can see it must be as much as 80% narrowed. So this is the mechanism how plaques enlarge, along with, of course, intraplaque hemorrhage. Where do these plaques occur? They predominantly occur, as shown here, in proximal LAD, in mid-right coronary artery, and proximal left circumflex. So they have to be related. Thin cap fibroathroma, same place. Acute plaque rupture incidence is very similar, same way heel plaque ruptures. So we believe, again, because of the site where they occur. Therefore, this must be the mechanism. Now, I just want to touch briefly on macrophage diversity. There is a lot of macrophage diversity. In the old days, we believed there were only one type of macrophages, and we showed cholesterol. This M1 macrophages, which is the foamy macrophage, this is rich in TNF alpha. They secrete IL-1, IL-6, as well as IL-12. They are atherogenic. You can have M2 macrophages, which are supposed to be atheroprotective. They secrete IL-10 and IL-4. The ones we described was hemoglobin, heptoglobin complex macrophages. These are CD163 positive, and they actually are not, they used to be thinking that this is atheroprotective, and I'll try and convince you they are not really atheroprotective. Oxidized phospholipids, MOX macrophages, which form the foamy macrophage. And then there's the CXCL4, that is M4 macrophages. They have reduced phagocytosis, atherogenic. These take up oxidized LDL. So what we did some time ago, we wanted to understand what is the difference between why there is hemoglobin, haptoglobin complexes, these protect from foam cell formation, because we saw macrophages within the plaque that were CD163 positive and did not have any lipid in them. And so what we did in culture, we exposed the oil red O positive cells as expressed here, looking at oxidized LDL in control. They wouldn't take up oxidized LDL, is taken up by these macrophages, controlled macrophages. IL-6, IL-4 takes up some oxidized LDL. But if you look at the hemoglobin, heptoglobin exposed macrophages, they don't take up any lipid. Same way here, what we tried to do was to understand how much total cholesterol, free cholesterol, esterified cholesterol is taken up. If you look at the control cell, that is M1 macrophages, they take up total cholesterol, free cholesterol, some esterified cholesterol as well. But if you look at the hemoglobin, heptoglobin cells, and you just expose them to LDL, there is increase in total, but very little increase. Whereas here you can see the comparison, there's marked increase. Same way, if you look at oxidized LDL take up, it takes markedly large amount of cholesterol, free cholesterol. Heptoglobin, hemoglobin, oxidized LDL, they take up but very little, and very little cholesterol ester. So there are differences in the type of macrophages. Then we also showed that in the plaque itself, in the areas of angiogenesis and hemorrhage and iron presence, in those areas, the type of macrophages that we see are different than those that we see near the necrotic core, as shown here. These are the control area near the necrotic core. This is the area of angiogenesis, iron presence, hemorrhage, angiogenesis, and none of the above. These areas, as you can see in this case, there was none of the above. And you can see here, we did control macrophage area, and we looked at the area with angiogenesis. You can see CD68 are present in both. You can see CD163 predominantly only in the area of the hemorrhage presence and angiogenesis and iron. CD206, which is the mannose receptor, much more in CD163, that is in the area of this hemorrhage. And then if you look at CD30, that these are the scavenger receptor, you can see that this is mostly expressed only in control, that is M1 macrophages in the area of necrotic core. And if you look at oil red O uptake, is much more so in the area of necrotic core, but the CD163 cells take up very little of lipid. This is just showing the same. Further enlarging on it, we showed that iron was related, and iron, this leads to HIF1 alpha activation that releases VEGF, and that VEGF then goes and causes proliferation of smooth muscle cells, not endothelial cells, and angiogenesis, and that VEGF also increases permeability, and thus permeability then brings in more macrophages, and the same cycle is repeated. Therefore, this is not a benign phenomenon, but actually an active phenomenon. So I'm going to switch now to plaque erosion. Plaque erosion occurs in 30 to 35% of thrombi. In sudden coronary death, you can see erosion in a 33-year-old woman who complained of chest pain for 2 weeks and was discharged from the emergency room with a diagnosis of anxiety. You can see the luminal. She dies suddenly 2 weeks later while walking and is found dead. And you can see the lumen of the LAD shows a thrombus. You can see there is healing going on. You can see the multi-layer platelets presence, and you can see also fibrin present. And this area is from the healing likely that occurred within that 2-week period when she had gone at the first time to the emergency room. So we believe, let's go back. This, if you look at the underlying plaque, in these cases, the fibrous cap is always thick. You find lack of endothelium in these cells. I haven't shown that here. And you can see, again, similarly with those with necrotic core, you find that there are 50% show early, 34% show late, 16% PIT lesion, and that the endothelium is absent in the areas where we believe that what happens in plaque erosion is it's a vasospastic disease. Why is it more common in women? I can't explain that, but we think it's estrogen related, and that maybe is a protective mechanism against plaque rupture. So if you look at comparison of prevalence of calcium in lesional plaque rupture and plaque erosion, you can see there is much more calcium in plaque rupture, much less in plaque erosion. These are fragmented calcium is the most you see. As you can see, none in 56, 40% fragment calcium, sheet calcium, which is at least a quarter of the arc of the vessel, is involved with calcium. So difference between rupture and erosion, you can see here we showed that the luminal narrowing is greater in plaque rupture than in plaque erosion. And that is 78% versus 70%. And that what we show was the percent stenosis is also much less. Overall, you can see that less than 79% and 57% in plaque ruptures, but in 82% in plaque erosion. So vasospasm is a likely mechanism. We also showed plaque erosion. As you can see here, plaque erosion in men and women, stratified by age. You can see here 30s, 40s, 50s, 60s, and 70s. It occurs in men, but in a younger age group in the 30s. Whereas in women, up to the 50s, plaque erosion occurs, but it decreases over time and much less in the 60s. Now, if you look at the influence of age on coronary thrombosis in men and women, this is red is plaque rupture, plaque erosion, purple is calcified nodule, and stable plaques. If you look at females less than 50 years of age, majority have plaque erosion. If you look at plaque rupture, 11%, and most of those had high cholesterol. If you look at above 50 years, plaque rupture increases, plaque erosion decreases, calcified nodule becomes prominent as age advances, and same way stable plaques increase. If you look at males, less than 50 years, plaque rupture is the dominant factor, erosion much less, and calcified nodule is also present, but unusual. There, 47% showed stable plaque. If you look at beyond 50 years, 27% plaque ruptures, erosion even further less, and increase in calcified nodule and stable plaque increasing. So as age advances, the stable plaque also increase. So coronary calcification, I'm going to address that a little bit. This was Linda Deemer's work, who said we should classify calcification into three different types: inflammatory, which is atherosclerotic; metabolic, which is chronic kidney disease; diabetes mellitus. This is mostly media. It is not seen in the coronary arteries. It is seen in the peripheral arteries, specifically in the leg. And you can see there are other causes of medial calcification, which can be seen in the coronaries, but it is genetic factors that play the role. I'm not going to give all the... So this is just to show you atherosclerosis. You can see calcification very clearly in this X-ray of this artery, and you can see the calcium deposits black in this section. If you look at metabolic, that is diabetes, chronic renal failure, and dialysis patients, this is showing PAD, showing calcification of the media. You can see medial calcification, and you can see intimal. Coronaries usually don't show. The only one we see calcification in is medial calcification is idiopathic arterial calcification of infancy and other genetic causes. This is related to ENPP1 gene. And you can see the medial calcification right here and the luminal narrowing in this secondary to intimal proliferation. So what about progression of coronary calcification in atherosclerosis? If you look at early disease, that is, this is pathologic intimal thickening, this is necrotic core, and you can see here microcalcifications are seen, which are less than 0.5 micron. Punctate is larger because it's macrophage-related calcification, these macrophage undergoing 5 to 15 micron. And if you look at fragment calcification, this involves collagen as well. You can see the fragment is usually on the abluminal surface, as you can see right here. There's calcification deposition, as well as macrophage deposition. Now, sheet calcium, what we classify as sheet calcium, it must involve at least a quarter of the circle of the artery. And you can see here this calcium, which is sheet collagen calcium. If you decalcify and you stain with serous red and use polarized light, you can see this is type 1 collagen, yet there is calcification there. On the other hand, if you look at the necrotic core calcium, that is necrotic core sheet, if you decalcify and you stain with serous red, there is no matrix, absence of matrix. So the strength in this is not as much as the strength in this collagen or this calcium, that is collagen sheet versus necrotic core sheet. And I'll come back to the importance of it. Nodular calcification, you can see is much less. You can see, we believe that this occurs from the nodular calcium, which breaks up, and then this necrotic core calcium will break up and fills into the lumen, especially here, calcified nodule with a luminal thrombus. And you can see bone formation, which occurs less than 5% of the cases is seen, much more common in peripheral vascular disease. This is to show you one CASA, which stains for calcium. You can see the black is the microcalcification in early lesions, pathologic intimal thickening, as well as in early fibroatheromas. You can see as they become necrotic core fibroatheromas, you see punctate calcification. Why do these cells show the smooth muscle cells in PIT start to disappear? Basement membrane becomes big. Why they undergo, we don't know, but the smooth muscle cells begin to die as shown here. Basement membrane is increased. And what we see eventually is these areas with large amount of basement membrane have calcium in the middle of these areas. You can see this calcium deposition. And then it can spread into the surrounding collagen areas and form calcium. This is to show you calcification of radiography. You can see by radiogram, you can see that this is plaque erosion, has the least speckled. You can see speckled calcium in case of thin cap fibroatheroma. This is showing you the speckle, which is less than 1 millimeter. And then when you look at ruptured plaques, you can see that in this, there is calcium. It is mostly on the abluminal side, means on the medial side, you see heel plaque ruptures start to calcify much more. You see more diffuse, and then fibrocalcific has the most diffuse calcification. This is just to show you by micro CT, we can see calcium very clearly. These were done before decalcifying these lesions, the micro CT. This, you can see plaque erosion, thin cap fibroatheroma, ruptures, healed ruptures, fibrocalcific plaques. The most in erosions, you mostly see speckled or no. Thin cap, this is in radiograph, you see either speckled, diffuse, or fragmented. If you look at ruptures, predominantly it is speckled and fragmented. If you look at heel plaque ruptures, you see diffuse much more and fragmented. And in case of fibrocalcific, mostly fragmented and diffuse calcification. And similarly, if you look at histologic sections and look at calcification, you can see it is microcalcification or fragmented erosion. In thin cap, there is very little sheet calcium, predominantly microfragment or none. In ruptures, none, microfragmented, very little sheet calcium. Heel plaque rupture, similarly, you see a higher incidence of sheet and fragmented, and then fibrocalcific plaque, you see lots of sheet calcium. This is, I think all of you know, I don't have to go through, and since I'm running out of time, I'm going to show that as the plaque increases, so does calcification increase, except beyond 80%, it tends to decrease the calcium because these lesions may be more related to ruptures. And if you look at percent area narrowing, similarly, the yellow is the necrotic core, blue shows calcium, and then the purple, this shows the amount of narrowing there is in blue. And then if you look at the purple is calcium and necrotic core. The larger the necrotic core, the less the calcium there is. The smaller the necrotic core, the more the calcium there is. So this is to show male, females. Females only catch up much later in life. If you look at black, white, similarly, white have more calcium than the blacks. And if you look at males, females, males have much more calcium, except in the 70s and 80s. In 80s, even there is much more calcium in women than even in men. This is, I'm going to skip this. This is something we did some time ago. We just published this: mild calcification, moderate calcification, and severe calcification. As you can see, this is radiograph of the arteries taken off the heart. And what we show here by decade, you can see that these are CAD patients, coronary artery disease patients. If you look at 20s, 30s, 40s, 50s, mild, moderate, and severe, you can see in the 80s severe calcium. And if you look at by decade, these are non-cardiac death. It increases with age, but not as much as in coronary artery disease. And if you look at plaque erosion, plaque ruptures, erosions have the least calcium. Ruptures are the next least. Highest is in calcified nodule, stable plaque much more, and non-CAD disease the least calcium. So I will end here by saying that, mutually exclusive theories for vascular calcification. I am a believer of cell death, smooth muscle cells, apoptosis, and macrophage necrosis are the main mechanism. If you look at vascular overall hyperphosphatemia and hypocalcemia in renal failure, and then if you look at circulating nucleational complexes or matrix vesicles are released, this is a second theory. Induction of bone formation is another. Loss of inhibition is another. And then there are matrix vesicle as the main cause is what people believe. I believe it is more related to cell death. So I'm going to end here since I don't have that much time. This is calcified nodule, just to show you the nodules. One of the things we showed here was that the culprit lesion, we have much more necrotic core calcium as compared to collagen calcium. Collagen calcium much more at the ends, at the proximal and distal ends of the lesion. And here showing you that in micro CT, you can see this nodule is protruding into the lumen. You can see solid calcium at the ends and likely these solid calcium make that when the artery undergoes systole, diastole, or if there is sudden rise in pressure, that could, I'm sorry, you can see that there is, these are the two areas where you find fibrocalcific plaques, proximal and distal. At the culprit site, this is the necrotic core plaque, which is weak, and therefore the necrotic core calcium bulges into the lumen from the constant movement that can occur in highly tortuous arteries. So in summary, this is what I showed you: plaque rupture and plaque erosion. Those are the two main causes. Calcified nodules unusual. Macrophages are important. And I showed you coronary calcification and its mechanism. And that early calcification occurs in apoptotic smooth muscle cells and macrophages. Others view as a process of autophagy, microvesicles, or microparticles similar to matrix vesicles of skeletal bone. So thank you so much for this. And I am open for questions.
Thank you so much, Dr. Virmani. That was an amazing lecture. I think so much different information that what we usually see. So thank you so much. For everyone, please put your questions in the Q&A and we'll go through them. And there you have the CME if you want to just get some CME from the lecture. I'll start with one question. From your pathology perspective, now with newer medications, we can push to these very low levels of LDL below even 20 milligrams per deciliter. How much residual risk can we still have? Can we still be forming plaques or doing plaque progression at those levels? And what's the role of aspirin when we reach these very, very low levels, do you think?
A complex question, of course. So if you can, I think what happens with when you lower you lower the cholesterol levels in LDL cholesterol. If you lower them really low, what happens is very little can come into the vessel. So therefore, you are preventing macrophage formation, foam cell formation, and therefore there is no activity. There's less activity within the plaque. Now, what is unusual when we lower is we start getting calcification. What if we started? I think that is because we've already got a necrotic core, we've got cells, they will die because they're not getting more, and they can't quite leave. Macrophages can't quite leave a fibrous plaque. If they're surrounded by collagen, type 1 collagen, they can't migrate through a long distance. So therefore, they die there and they get calcified. So because all of us have calcium phosphate product, I think calcium precipitates, and that is why we get more calcium if you look at with statins or with PCSK9. And I think this is a complex. I think if you started very early and didn't let plaques form, you wouldn't have that much of a problem of calcification.
That's great. Thank you. Thank you. Very, very important. I think if we treat these plaques early, there's some data that suggests you can have more regression, right?
Yes. I'm a believer. Every 18-year-old must know its cholesterol and LDL cholesterol as they get out to be adults. At the age of 35, 40, everyone must have a CT.
Well, I must agree on that, but obviously I do. Okay, great. So related to this from Rob Oswell, I think a very good question. He says, can you share your thoughts on these, very low levels of LDL that we can reach and the changes in the phenotype of the plaque with the increase in fibrous cap thickening and more collagen? Is that just LDL, or what are your thoughts on that?
I think basically, I don't believe necrotic cores shrink, okay? People have said that the necrotic core becomes less. I think what is happening is there is more collagen laying down. It's trying to repair itself, trying to get rid of that, but it can only do it because cells can't come and pick up the cholesterol from there or cholesterol esters and take it out. They can't migrate in a collagen scar area. They can't migrate into it. So therefore, what happens is it envelops. It is a protective mechanism. That's what I believe in, that it protects the patient like an abscess in a way. Abscess wall off. They try to protect that. And yet bacteria can live in that for a long time. And that necrotic core, I think, can get calcified and maybe get totally rid of the necrotic core with time, I think decades, but not within a year or 2 years. You'll see some increase in calcium, but I don't think it's that much.
Very good. Yeah, we need these improvements in cholesterol over long
Yes.
periods of time, like you're saying. We have a question from our chief, Mario Garcia. He says, "Great presentation, a lifetime of research summarized in 1 hour." I couldn't agree more. Very good question. Does perivascular fat play any role, or is it just an epiphenomenon?
I think perivascular fat plays no role. I think what plays the role is inflammation. What we will show is that I've looked at fat. People have shown in animals, you can get fat necrosis when there is a lot of inflammation. But I have never seen fat necrosis in a patient with coronary artery disease. There can be inflammation in the adventitia from, say, pericarditis or something. That would be different. What you're seeing is inflammation in the adventitia medial borders, and you are saying that this inflammation is secondary to fat, which is decreased. Now, it's really, if you look at a proportion, adventitial thickness is proportional to the intimal thickness. It's not the same. The ratio may be 1 to 4, okay? So we will show this. We are actually in the throes of doing this work to convince the people it is not fat you are modifying. What you're modifying is the inflammation. You're looking at inflammation in the fat index. You're not really looking at inflammation and fibrosis.
Thank you very much. We have a question from Carlos Rodriguez. He has race differences in coronary calcifications exist. Black individuals have higher cardiovascular mortality than whites. Is it partially due to lack of correlation of calcifications with non-calcified plaques? This is a very important point. I think the differences in calcification between races. Is it the races or are the risk factors? What are your thoughts?
Overall, there is no doubt we see less calcification in African Americans than we see and that has been shown by others. And people think it is genetically related rather than. Now, I don't think they have less coronary disease. They have plaque ruptures, they have others, and they have hypertension on top of that. Remember, the incidence of hypertension is much higher in African American than it is in the white race. So I think it compensates for one for the other. Calcium, where do plaque ruptures? I wasn't able to quite show you that if you look at plaque rupture sites, there isn't that severe calcification in those sites. Severe calcification is only when it is a stable plaque and it gets calcified. And especially in patients who are diabetic, who are in or renal dialysis or chronic kidney disease. And that also is very high in the African American. Again, diabetes is higher in them than in the white race.
Yeah, many times in this, especially with CT, we call these microcalcifications as vulnerable plaque or high-risk plaque. But what we're seeing with CT, do you think is this really these microcalcifications or we're overcalling that?
I don't think they're microcalcification. I think what you're seeing is fragmented calcium and sheet calcium. You cannot identify microcalcifications. I do not believe that you can. Now, fluoride 18, they are showing that you can see early calcification, and I actually worked with them. I'm not convinced that it is early calcification. It is calcification there, see.
Very good. Should we, from Omar Said, then, should we be targeting this with medications and novel therapeutics, a reduced level of coronary calcification, or this is protective and is good? And
Yeah. I believe it is more protective. Early is not, up to fragmented is not. Beyond that, I think it is protective. If you get sheet calcium and highly calcified arteries, I wouldn't treat those with percutaneous methods at all, because I think you're wasting your time. You cannot get rid of that calcium. I mean, we've seen coronary arteries with greater than 20% of the tree with calcium. That's not uncommon at all. And those are the ones that get calcified nodules because they break. Same way in the leg. What we've seen below the knee is we've seen medial calcification without any atherosclerosis. It's really 10% or 15% will have atherosclerotic disease below the knee. It is really medial calcification and embolic disease more common than is atherosclerotic.
thank you very much. A question from Aldo Skinone. Thanks for the amazing conference, he says. And I think this is a very, very important question, and something that even how we define here in our labs, it creates a lot of confusion. So he says, based on your experience, what would you say a normal or optimal LDL level should be for the general population with not known atherosclerosis to prevent CAD?
I certainly believe less than 150 in an adult. Do I say that we should have kids less than 150? No, I wouldn't do that. I would say beyond the 18 years, we must reduce the cholesterol level. And, those with homozygous LDL and homozygous disease lipoprotein, I think those are different. You've got to treat real early, in childhood, in fact. So I think treating cholesterol must be less than 150 in early childhood or so.
The total cholesterol, you mean, or LDL?
Total cholesterol.
Total cholesterol. And the LDL probably even lower.
Lower, even, of course, even lower. Yes. I mean, close to, I would say, 70 or 80 at most.
Thank you very much. Another question from Rob Osfeld. I think it's very interesting what you're mentioning about the red blood cells. So this is an important question. He says, thank you again for a terrific talk. In a small study of 10 humans that you published in laboratory investigation, a single high-fat meal led to morphologic changes in red blood cells, in addition to a single fat meal making red blood cells more pro-oxidant and more pro-inflammatory and became spiker. What is the role of these spiky red blood cells? Could they have a mechanical effect on the fibrous cap, or what are the...
I don't believe in the mechanical effect. I think remember, they are more crystalline at lower temperatures. And the body temperature is much higher. I do not believe that they're so needle-like in vivo. I think it is only ex vivo because that's how we see them. Although you can see some crystalline, I have seen in OCT, I have to say that. But that was only after taking the artery off. So one has to be a little, take it with a pinch of salt if you're seeing that. And saying it that it ruptures the fibrous cap, I do not believe it.
Thank you very much.
One such case where there was cholesterol, we published that one case. That's the only case I've seen after having looked at thousands of cases. I mean, all these cases, I personally have looked at all of them.
Thank you very much. I think to finish, I'd like to ask a question about the vulnerable plaque versus vulnerable patient theories. And now there's some studies in suggesting, stenting vulnerable plaques. Do you think we should keep chasing the vulnerable plaque? Is that possible to identify with imaging?
I think it is possible to identify, especially with OCT, I think. And Not as yet by CT. I will say we cannot identify thin cap. We can only say it is rich in lipid. One of the problems also is you cannot differentiate lipid pool from a necrotic core. And lipid pool is not that dangerous. It is the necrotic core which is the dangerous. So I don't think we have as yet the tools. Once you make it, in micro CT, I can tell you apart. Okay. So we need resolution. We don't have that resolution as yet.
Thank you very much. This was a wonderful lecture, very inspiring. And again, congratulations for your amazing career and looking forward to seeing you in person soon.
Yes, thank you so much for having me. It's my
Bye-bye.
pleasure to be here.
Take
Thank
care.
you. Bye.